Okay, I'm going to call the meeting to order. As we all know, today is Veterans Day, and I want to thank the men and women who have served our country and their families that have supported them during this time. I also want the community to be aware of how Washington Hospital Healthcare System recognizes its veteran team members. Later in this meeting, our CEO, Kimberly Hartz, will be sharing more about that recognition. Now, please stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, undivided, with liberty and justice for all. Thank you all. Deep, would you please take the roll?
Okay.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee.
Present.
Director Ethan.
Present.
Director Stewart.
Present.
Okay. Thank you. Thank you very much. We are now going to move to the consent calendar in our agenda. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or the member of the public requests to remove an agenda item from the consent calendar. Oh, wait a minute. I'm sorry. I think I jumped the gun. I'm sorry. I apologize. We just had the roll. I'm going to retreat now to the my opening remarks. I apologize. I want to welcome you all to our meeting on this eventful day. To comply with Alameda County's Order Number 2015 as revised on October 23rd, 2020, to slow the spread of COVID-19 and to maintain restrictions on movement and public gathering, this meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. Governor Newsom's Executive Order N-2920 explicitly waives the Brown Act provisions that requires the physical presence of members, the clerk, or of the public as a condition or participation in or quorum for a public meeting. We continue to comply with the Brown Act in providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Members of the public are invited to speak during oral communication. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and with the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak this evening? I will now continue with the agenda, and I'm back to our consent calendar. Thank you all. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? Okay, may I have a motion to approve consent calendar items A through F?
In accordance with the district law policies and procedures, I move that the board of directors approve the consent calendar items A through F.
Thank you, Dr. Epen. Okay, may I have a second, please?
Second.
Thank you, Jeannie. Okay, please, Dee, please take the vote.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Epen,
Aye.
Director Stewart.
Aye.
Okay, at this point, I want to move on to the, normally it would go to oral communications, but I want to take up a commendation for a man who has been a friend to our hospital in many ways and an advocate for Southern Alameda County and particularly Fremont, and being one of our own Fremont people and a good friend who has looked out for all of us during his tenure on the Board of Supervisors. So tonight we are honoring Scott Haggerty for his many years of service as a member of the Board of Supervisors. And I'm going to read his commendation. In recognition of his dedication and commitment to the Washington Township Healthcare District, Washington Hospital Healthcare System, and Washington Township Healthcare District formally recognize and acknowledge Supervisor Scott Haggerty for representing the First District of Alameda County for 24 consecutive years, from 1996 to 2020. During his time in office, Supervisor Haggerty has dedicated himself to the residents of the district that he represents. His leadership and support in the Tri-City area has enriched the lives of many through his tireless support of nonprofit organizations and the arts community. The financial support he has directed to house the homeless and has helped the most vulnerable population in Southern Alameda County. His work has led to more than $2 billion in transportation infrastructure improvements and the development of the Valley Link Rail project. Through his constant advocacy and actions over the years, Supervisor Haggerty has helped improve the quality of life in people in Southern Alameda County by increasing access to high quality health care. He has directed more than $225,000 in discretionary Measure A funding to Washington Hospital Healthcare Foundation to support key programs to improve the health of our patients and the community. These programs include the Washington Hospital's Community Mammography Program, which provides mammograms to uninsured and indigent women. The funds also help equip the biplane catheterization laboratory, important life-saving patient care equipment in critical care, and the resuscitation rooms in the emergency department in the Morris Hyman Critical Care Pavilion. In these and countless other ways, Supervisor Haggerty has contributed to Washington Hospital healthcare system's patient-first ethic and the district's mission to meet the healthcare needs of the community now and into the future. With highest regards and accolades, we proudly present this certificate of commendation in honor of Alameda County Supervisor Scott Haggerty. I just want to say that it has been a great pleasure and honor to know Scott over all these many years. And I know that he was close buddies with our good friend Taylor Bell, who at one time was counsel for our hospital district board, who passed away at an early age from a brain cancer. And it touched all of us. And I know that Taylor is in heaven, and he truly loves his buddy Scott as we do. So I'm just thrilled to be able to commend Scott at this point.
Mike, thank you. Thank you to you and Naomi for the friendship over the years, to members of the board that I've known for as long as I've been in elected office. You know, I just want to say that you mentioned Taylor, and I think one of the first times Angus shook money out of me was for the Gamma Knife building that was being done. And I can say that between Nancy, Angus, and Kimberly, they've all been very successful in knowing how much is in the Measure A bank account at any given moment for District 1. But I can tell you, I've always been really happy to help. And first of all, in relationship to Taylor, you know, when you were talking, Mike, I was starting to get tears in my eyes because I was thinking about Taylor. And just a little update on Taylor. His son, Lawson, has been working for me for just about a little over a year. And when Lawson first came to me, he wasn't sure what he wanted to do. And I said, well, I think your father wants you to go to law school. So he's going to law school. In fact, he's taking his LSAT. He's getting ready to move. But I can tell you, he is just as brilliant as his father Taylor was. And he's doing a great job for us. I want to say that, you know, I grew up with Washington Hospital. I was there when I was thrown on my head in a wrestling tournament and couldn't move for a while. And, you know, I remember my dad coming in and then saying, gee, Scott, couldn't you wear clean underwear? You know, so we all have memories at the hospital. And, you know, my daughter was born there. My kids have been there over the years, and it's always just been top-notch care. And I have to tell you that it's really easy to support a hospital like Washington Township because of the management that it's had over the years, because of the board, and because of its mission of really just taking care of the patients. I know, Mike, you get frustrated with me in relationship to the trauma center. Maybe now that I'll be a private sector guy, we can work on that together, because I do believe Southern Fremont needs a trauma center. I've never ever, you know, wavered in that. I just need to convince the people up in Oakland that it needs a trauma center. But you guys are well equipped, you're well positioned, and I find it tragic when a police officer in the city of Fremont gets shot and gets transferred down to San Jose. And he could have just stayed here. So I think there's been wins, and I think there's wins that still need to come. I will say this also, that I think I leave you in good hands. The new supervisor will be keeping my chief of staff, and they'll hit the ground running. He's a good guy. He believes in healthcare, and he'll be, you know, good to Angus too. I'm sure Angus will find his back left pocket to pull the wallet out and make sure the checks are being written. So I want to thank you. I haven't agreed to do many of these going away things because quite frankly, it's kind of rough on me. But when Kimberly called the office, I wanted to do this one just because I have a lot of respect for, you know, you and all of you, and for Kimberly and Nancy Farber. I would like to say that too. You know, it's been a great partnership, not only the years of my political years, but my private years too, when I was either utilizing the hospital or one of my family members were, mother, dad, you know. So we have great times at that hospital, and we have some pretty bad times, but always knowing that they got the best care possible. So, you know, thank you. I appreciate it. And I look forward to continuing to work with you all in the future.
Supervisor Hegarty, this is Kimberly, and I do want to just say it has been a true friendship and partnership. I know that at any time when we had issues that you were always there on the other line in terms of listening and trying to help. I know that we may not have always resolved all those issues, but you were always there willing to listen. And, you know, I've always appreciated that in my role previously, and now, especially in my role now. So you will be missed, but you have made an impact on the health of this community and our patients by helping to support us when we needed that. So thank you, and I hope I have your commendation here. And as I said, hopefully I can come and bring it to you in person. So I do want to do that. And I look forward to continuing working together, even as you become into the more the private sector. So there's always work that we can all do together. So thank you again for all of your support over the years.
Thank you, Kimberly. And I'd just like to say that every time I think of you, I think of the times that my daughter worked at the hospital, and she so loved that job, and she loved working for you. So, you know, it's been great. It's been great. And I'm sure when you come, Angus will come in behind you and ask how much red measure you want to have left.
That's right.
Well, I just want to say that, I mean, I don't think we got to where we are with the healthcare district by accident. I think it had to do a lot with collaboration. And Scott, you had a lot to do with supporting us over the years. And man, we love you, and we hope you have a great retirement in Tennessee. And maybe we'll come over there and visit you sometime, hang out, you know. It seems like everybody's talking about Nashville and Tennessee all the time now, so.
Well,
think
I'll tell you, Mike, that whole Tennessee thing is like the worst kept secret. Probably partly because I keep telling everybody I'm going there and say, don't tell anybody. But yeah, it's beautiful in Tennessee.
Well, thank you, my friend, and good luck, and God bless you.
Thank you.
Care.
God bless all of you. I appreciate it. Kimberly, I look forward to seeing you next week.
All right. We'll get together. So that sounds great.
Okay, we are now going to move on. We're going to go out of order, and we're going to, Kimberly, you're going to make some announcements.
Right. I'd like to do one of my announcements now. I really would like to introduce Larry Tramatola. I know that many of the board members, all of the board members know Larry. He is a consultant, has been a consultant to the healthcare district for numerous years. And as we all know, the board of directors voted to place a bond measure on the ballot for the November 2020 ballot. And Larry is going to talk a little bit about where things stand with that bond measure. As we're all very aware, the county is continuing to count votes, and so we felt it was important that we talk about it, have Larry come and give an update as to where things stand today. And we are ahead at this point in the total, but I'm going to turn it over to Larry to give us the full update. So. Thank you.
Thank you. Can you hear me?
Yes.
Great.
Yes, yes.
I know that Supervisor Haggerty has left the meeting, but I would like to add my congratulations to him as well. He was, when I ran the Measure A campaign and the renewal campaign, he was critical to helping raise money and to making sure that happened, and has helped countless people throughout the county for that. And he's had a long, distinguished career. And so I wish him well. Also, I want to congratulate board members Nicholson and Yee for their victories in this election. That is, I think, a real tribute to the work that they've been doing for some long time and some short periods of time. So, but what I was here to do was talk about Measure XX, and I can pretty safely say, as I've said to several of you, I think it is won. And here is why I say that. While the county is counting ballots, and regrettably today was a holiday, or they would have finished today, they will finish tomorrow, at least a preliminary count. There are only 9,000 ballots left to count in Alameda County. And if we look at our portion is about 18%, and we don't know whether it's 18%. It could be far less than that on the ballots that are left. But if it is 18, then there's about 1,620 votes or ballots that would be counted in this district. We could actually lose those ballots 2-1 and still win. It is now almost mathematically impossible for us to lose. Now, Do we want to say that publicly? Probably not yet. We believe well, this is public, but we don't want to. We don't want to do press releases or or claim victory and all that too soon, because I think it's important to make sure every vote is counted. People spend a lot of time trying to determine how they're going to vote on these, and I think that we owe it to them, and we of course want to be sure. But it is quite a remarkable victory, and as I told people earlier, it would not have happened without the things that Supervisor Haggerty alluded to. The quality work of people in the hospital for years and years and years. I think your leadership as directors on the board and the leadership of the administration, I feel we had the wind at our back because we were asking people to support a quality institution and not take a leap of faith that we were going to do things well, but people had trust that you were going to do that. And passing a third bond is not an insignificant thing. It's never been done in California, ever. And for a bond of this size to finish the work that you're doing was pretty incredible. And I just want to acknowledge you. You made tough decisions all the way down the line. Mike told me months ago that he didn't want to pay for a landslide. Well, he didn't. I think we used every penny effectively, and I think we correctly had the right message. But I really wanted to congratulate you. I'll come when we have final results again, and I'm hopeful at some point in being able to do a map that says how we did percentage-wise in every single precinct in the district. That could be helpful as well. But for all of you and your amazing staff, from Tina and Angus to the nurses, I mean, all the people that volunteered to make calls, it wouldn't have happened in an election, even though we'll be 700, 800 votes probably over the margin of 2/3. Each of those votes comes hard. Each of those votes takes conversation and deliberation. And so I just want to acknowledge your amazing staff and truly say that it is always an honor to work with each one of you. I think it's a highlight of my professional life to do that. So congratulations to all you. And I think maybe by the end of the week, we'll be able to put out a press release that thanks people and acknowledges the victory.
Thank you, Larry. Are there any questions? Okay, well.
No questions, just I think, Larry, we can't thank you enough. You are always a pleasure to work with. And I know it's not in stone yet, but I remember so well when you were advising us early on and you said how difficult it would be to pass a third bond. And I didn't realize that it had never been done in California. That's significant, and your help is a major part of that. What you've told us and advised us to do, it is amazing. And I just personally wanted to thank you. It's always a pleasure to see you and work with you, and I appreciate how you threaded the needle on this one.
Yeah, you'd like to have a little bit a bigger needle, but whatever had happened, it worked, and I think there were a number of things that made it. A lot of it has to do with the testimonials from your staff and the testimonials from the people that have used the hospital. So again, our job is to use your resources, both human and financial and time, in the best ways possible, and we couldn't do that unless we had a great team. So I thank you for your words, and I appreciate it. Our job is hopefully, I was going to say when I started, if we had lost you, I wouldn't be on camera, but that's not true. I would do that either way, and it's always a pleasure to work with you all.
Yeah, I want to thank you too, Larry, and I know there's a lot of people that donated their time, the staff that, you know, off hours and times that they put towards with everything, and the friends of the healthcare system. So, but thank you for all that you've done in terms of advising. So we appreciate that and the work you've done.
All right. Thank you. Appreciate it.
Thank you.
I think there's a lot to be said about the fact that it's a challenge to really get the word out. First of all, there is a love for Washington Hospital throughout our district because of all the care that we've given over the years. The challenge, though, is having people understand that they are actually the owners of the hospital system. California is one of the few states in the United States that was blessed with having a district hospital system. And that means that the residents of the community own the district hospital. They own it. And that's why great people like Bill Nicholson and Jeannie Yee were up for election and got elected this time. It is a great thing, but not a lot of people. I'm going to change that. Many people don't know that they are owners of the hospital system and have a say in the outcome. And so the communication challenge on an ongoing basis for everything is tough, and a political campaign is really tough. And the strategies and the messaging and everything that was done during this campaign has been just like absolutely what was needed in order to get us to where we are. We're not over the finish line, but thank God we're over where we need to be at the moment, and we have still 9,000 countywide votes to count. So I just want to thank Larry and his team for helping us with that communication. It's many people would think it's obvious. It's not obvious. It's very hard. People don't think about a hospital until they need it. And that is the reality of all of our lives. And thank goodness where we stand right now, there have been enough people that have thought about that and said, or maybe even in their lives. I know there's a lot of newcomers to our district that have never actually used the hospital, but I think they understand the importance of it. So the message was important, and Larry's advice and efforts in helping us get that message across was critical and much appreciated. So thank you, Larry. You've done great. We'll see what happens tomorrow. We're good. We're okay right now. You know, I don't like that. You know, you don't want to say anything until it's done. Okay. Does anybody want to add or say anything else? All right. So are there any other, Dee, are there any other oral communications?
There are not.
How about any written communications?
No written communications.
Okay, then Kimberly, I think we're going to move on to the agenda.
Correct. We have 3 presentations this evening. I'm going to start with Dr. David Lee. And let me introduce Dr. Lee. He's going to be talking about cancer immunotherapy. And Dr. Lee is the co-medical director of the UCSF-Washington Cancer Center that we all know is located here. at Washington Hospital. Dr. Lee earned his medical degree from New York Medical College and then completed his internal medicine residency at the UCLA Medical Center. He remained at UCLA as a chief resident in internal medicine, followed by a fellowship in hematology and oncology. Dr. Lee moved to the Bay Area in 2008 and joined UCSF in January 2017, helping to establish and expand the cancer services at Washington Hospital. He's board certified in both hematology and oncology, caring for all types of solid cancers, blood cancers, and also benign blood disorders. He is dedicated to providing compassionate, individualized care to his patients and ensuring the best possible cancer care in our community.
Thank you, Kimberly. Can everybody hear me okay?
Yes, we can hear you.
Great. Thank you to the board and to all the residents for this opportunity to speak about a pretty exciting type of treatment for cancer patients and what we call immunotherapy. If I could get the next slide, please. So the immune system refers to the different organs, blood cells, and proteins that work together to protect our body from infections. The immune system is highly coordinated. It is adaptive, meaning that the immune system can fight off a whole host of problems, whether it be bacteria, viruses, or fungi, to help keep us safe. And the immune system is constantly on duty. It's on surveillance, looking out for infections and making sure that we're safe. Can we please advance? The most basic function of the immune system is what is called self-non-self recognition. That is, the immune system is trained to recognize our body cells. It will tolerate our body cells and leave our own body alone. And anything else that doesn't look like our own self, the immune system will attack. It doesn't matter if it's a bacteria, a virus, a fungus, a foreign body, even a foreign organ in the case of organ transplant patients. And generally speaking, the immune system does this job very, very well. Of course, there can be problems with the immune system. Many people may know other individuals, they may have friends or family with what we call autoimmune disorders. And with autoimmune diseases, the immune system has a problem where instead of recognizing our own body, it actually may target and start to fight off and attack a part of the body, whether that be the joints, like in rheumatoid arthritis, or the intestines in Crohn's disease or ulcerative colitis. With autoimmune disease, the immune system no longer recognizes itself properly and starts to attack their own body. Similarly, if you get an organ transplant, you must take anti-rejection medicines that suppress the immune system, generally for life. Next slide, please. This looks fairly complicated, but it's not. What it's saying is at the top, we have what are called B cells, killer cells, helper T cells. These are just white blood cells that are part of the immune system, and they fight off infections. And what they do is they circulate through our body and our bloodstream, and they're constantly looking at our cells and make sure everything is going according to plan and nothing is amiss. So in the first panel and the third panel, the B cells, the helper T cells, they're coming by and they do what's called like a handshake. And they're using their receptors on their surface to look at different antigens that are part of our cell. Antigens are like unique proteins, unique sugar molecules, and this is what the immune system recognizes as us. And in this case, it's a friendly handshake, and the immune cells will just go on and check somewhere else. In the middle panel, you have this killer cell that comes around and sees an infected cell. And there's this new antigenic peptide or protein that it doesn't recognize and doesn't see as normal as part of ourselves. And then now the killer cell, instead of having a friendly handshake, it's going to hold on tight. And it's going to start to attack the infected cells, as well as send out other signals to other immune cells to start to attack a particular type of infection. Next cell, please. Next slide. So if the immune system is constantly on alert and it's on surveillance, there's a question of why doesn't it recognize cancer? And that's because cancer cells are fundamentally our own body cells that have been damaged. And with enough damage, it transforms those cells so they start to take on characteristics like growth, spreading, or secreting proteins and hormones that can damage our body. And because these cancer cells started from our own self, then they can retain what are called self-antigens that allow it to evade the immune system. Also, cancer cells can actively suppress the immune system around the tumors, and cancer cells hide from the immune system. Next slide, please. Now, the idea of using immunotherapy is really, fascinating, and I think it's quite appealing. First off, we're using our own body rather than necessarily taking toxic chemicals like chemotherapy. Also, if you've ever seen somebody who's had a bad case of an autoimmune disease, you know that the immune system is quite potent because of the amount of damage it's doing, let's say, to a joint in rheumatoid arthritis, or the intestines in Crohn's disease or ulcerative colitis. If you've ever seen an organ being rejected after a transplant, you can see how the immune system can completely destroy organs and organ systems. Also, the immune system is adaptive, and the problem is cancer cells do not stay static. They're constantly changing, and as they change, they become stronger and stronger and more resistant to chemotherapy. Oftentimes, when we use chemotherapy, initially, we get a nice response. We start to see tumors shrink up, people feeling better, and everybody's very positive about that. But as time goes on, cancer cells can become resistant to chemotherapy because chemotherapy drugs only work in one particular mechanism. And cancer cells adapt to that. And they start to change and they become resistant and they start to grow and progress. The immune system can adapt as cancer cells adapt, whereas chemotherapies, they just do what they do and they're stuck. Can I get the next slide, please? Now, the idea of immunotherapy is not new. Actually, you hear all the time of people who've had miraculous regressions in their tumors. And this is more so with certain types of cancers than others. This is very classic in what we call low-grade non-Hodgkin's lymphomas. You'll have somebody, I've seen patients that have large visible tumors in different parts of their body, which are enlarged lymph nodes from their lymphoma. And then all of a sudden they catch the flu or some other type of infection. And then as they're recovering from their infection, they can visibly see their tumors shrink up and go away. And that's because of the immune system that becomes activated to fight off the infection. And all of a sudden, now it recognizes that there's something else there, not just an infection, there's a cancer. And the immune system starts to attack the tumors. Also, when you do surgery and you remove cancers from a person's body, under the microscope, you can see immune cells actually infiltrating into the tumor, which always made us suspect that the immune system is trying to fight off the cancer. And then from an indirect way, we can say that patients who have suppressed immune systems, they frequently have more cancers and different types of cancers than people with normal immune systems. Next slide, please. So Dr. Coley is a surgeon. He's obviously now retired and passed away, but he was from the Hospital of Special Surgery in New York, which is an orthopedic surgery hospital. And he became interested in sarcomas when one of his early patients died of the disease. And he went back in time and he looked at all the different hospital charts of every patient in that hospital who had sarcoma. And he saw a case study of one patient who spontaneously got better and went into remission after he developed a serious strep infection. So he theorized that infections can help patients fight cancers. And he started actually doing a clinical trial in 1891 where he injected Streptococcus bacteria into cancer patients. It was a mixed result. Unfortunately, That was a time when we didn't have good antibiotics, and many of the patients that got infected unfortunately died from the infection. But he did have some success stories where some sarcoma patients actually went into remission, just like in that case study, because of the immune system. Can I get the next slide? Now, immunotherapy has been with us for decades. Early immunotherapy would be like a stem cell transplant when you get it from another person. We call those allogeneic stem cells or bone marrow transplants. And they work by giving high doses of chemotherapy to knock down leukemias and lymphomas. And then you get somebody else's stem cells, which creates new blood cells and a new immune system. And this new immune system can recognize leukemias and lymphomas and fight them off. There's also what's called interferon therapy, high-dose IL-2. These were used to treat aggressive skin cancers like melanoma and metastatic kidney cancer. Can I get the next slide, please? Now, if you follow baseball, baseball today is played very differently than baseball back in the 60s, 70s, 80s, even in the 90s. And I remember growing up seeing baseball players actually take walks, bunts, singles, steal bases, small ball. And nowadays, if you watch baseball, everybody's going for a home run. And it doesn't matter if you strike out, the more you strike out, it's okay, because the key is hitting home runs. And that's what high-dose IL-2 was when treating melanoma and kidney cancer. Most patients did not respond. The overall response rate to high-dose IL-2 was only 16%, which means that in 84% of cases, we struck out. But if you take patients who actually responded, in total, 6% had what's called a complete response rate, which means that all the cancer went away, and they were basically cured of a cancer that otherwise that would have killed them in the next 6 to 12 months. So they didn't just get a home run, they got a grand slam. Now, the problem though with this treatment was not only did it work in only a few cases, it also was very toxic. It was basically controlled sepsis that we were doing for days at a time, and the treatments would have to be repeated, usually at least 4 times to see if we'd get a response. Can I get the next slide, please? Now, newer immunotherapy is pretty much what we call checkpoint inhibitors. And checkpoint inhibitors refer back to the fact that the immune system will recognize yourself and tolerate yourself and just kill everything else. And there are these breaks, or what we call checkpoints on the immune system, that keeps the immune system from attacking our own body. And so checkpoint inhibitors start to release these various breaks, whether it be at the what we call CTLA-4 or PD-1, PD-L1. Now we've got various drugs that target these different checkpoints, and sometimes we use them alone, sometimes we use them in combination with chemotherapy, and sometimes we use 2 different checkpoint inhibitors in combination. Can I get the next slide, please? So this also looks pretty confusing, but I'm going to break it down in a pretty simple way. On the top left, what we're seeing is that handshake again, where the immune system is going to a normal cell, but actually in this case, it's not a normal cell, it's a tumor cell. And you would expect that the immune system could fight off the tumor cell and start to attack it, but it doesn't because of these receptors called PD-1 and PD-L1. And that actually keeps some immune cells, like certain T cells, it causes them to die off. Now, with these newer checkpoint inhibitor drugs, and in the bottom they show what is called Pembrolizumab, which is Keytruda, it shows that you can interrupt that inhibitory signal, which allows the immune system now to recognize the cancer and start to attack it. Next slide. This is a clinical trial that was published a few years ago in the New England Journal of Medicine, where they took patients who had stage 3 lung cancers where we could not do surgery. And normally, back then, we would treat patients with a combination of chemotherapy and radiation, and afterwards, we would leave them alone. and just monitor for cancer recurrence. Now, we would cure some patients with this combination, but most patients their cancer would return. And if you look at this orange curve on the bottom, that placebo is basically saying after you finish chemotherapy and radiation, if you just got a saline infusion every 2 weeks, that's what we would expect to happen. And that was pretty consistent with historical norms. And at 12 months since the start of the trial, meaning that they finished the chemotherapy and radiation, and they were just getting saline infusions, 1 year later, only 35% of patients were alive and without cancer in that placebo group. And if you go to 18 months out, only 27% of patients were alive and cancer-free. And the blue curve is Durvalumab, which is a type of immunotherapy. And you can see that there's a significant improvement at 12 months and 18 months. And the curves actually separate out pretty early on, meaning we start to see the immune system having an effect and helping to keep the cancer at bay and allowing more patients not just to live longer, but potentially to be cured. Can I get the next slide? This is a patient of mine. I took some screenshots of, on the left, a PET scan that was done when he was first diagnosed with cancer. This is a 77-year-old gentleman who came to the hospital just with excruciating right-sided chest pain, also chest pain right in the middle of his chest because he had cancer in his sternum, and shortness of breath. And he was diagnosed with the most common type of non-small cell lung cancer called lung adenocarcinoma. And this is like a cross section through his lungs on the left-hand side. And the dark areas, those are air. So the dark area on the right is the right lung. The dark area on the left is the left lung. The areas that are white are bone. And then the area that's orangish and reddish, that's the cancer that's eating away at his ribs and starting to infiltrate into parts of the lung. And there's another area smack in the middle of the right lung where you can see it's orange and red. That was part of his lung cancer where it started from. So he had a metastatic lung cancer, which was invading his bones, which was causing all of his pain. And he had what we call high PD-L1 expression of 90%, which is a good predictive marker that he would respond to immunotherapy. And all we gave him was Keytruda, which is a type of immunotherapy drug, no chemotherapy, no other type of treatment. And within about 1 to 2 treatments, his pain was all gone. And the scan you see now on the right, this was his scan after just 3 months of therapy. And you can see a remarkable difference in his cancer. And you can actually now see his ribs, that all the ribs that were being eaten up on the right side before by his cancer, because the cancer has been treated and the cancer is dying off, now the body is healing itself. Also in the lung, that spot that was bright orange, now that's going away as well. And this was just the 3-month interval scan. He's now about 9 months out from his initial diagnosis. His scans continue to show that he's had what we call a complete response or a remission. And what's very interesting about these lung cancer patients is even with stage 4 or metastatic lung cancer, we get a subset of patients that have this kind of robust response to immunotherapy. And if we treat them for even up to 2 years and you stop their immunotherapy treatments, many of them will go on and live for more than 5 years. And we can't say 10 or 20 years just because the drugs aren't that new. But at least in terms of the studies we've done so far and the follow-up, we can say that they can live with this disease basically as if it's a chronic disease and they're cured. Can I get the next slide? There's a different type of immunotherapy that's very exciting called CAR T-cell therapy. We do not do this here at Washington Hospital, but we have referred patients up to UCSF for CAR T-cell therapy. It was first approved in childhood ALL back in 2017. And this sounds like science fiction. What they do is people get hooked up to what's called a pheresis machine, which looks a lot like dialysis. And blood is taken out of your body. It goes into the machine. The machine spins the blood very, very rapidly. And as it does that, it separates out the different types of blood cells. And once you've separated out the different blood cells, you can use the machine to just collect one specific type, and the rest go back into the body. And so in the case of CAR T cells, we isolate out a person's T cells. These are then sent to a company where they take those T cells and they engineer this receptor on it. So that's why it's called a chimeric antigen receptor, or CAR T cell. And these engineered receptors allow the T cells to recognize leukemias and lymphomas and other blood cancers and start to attack it. And once they've made these CAR T cells, then they can multiply them and just grow them up in the lab, where you get millions and millions of these engineered T cells. And then a patient's admitted to the hospital, they're given chemotherapy and then the CAR T cells, and it could be potentially curative in childhood ALL. Can I get the next slide? It's also been FDA approved in aggressive B-cell non-Hodgkin's lymphomas in adults, and it's currently in trial in a different type of blood cancer called multiple myeloma. And UCSF has had 3 or 4 different multiple myeloma CAR T cell trials, and so far all the preliminary data looks very good, where multiple myeloma is not considered a curable cancer generally, but now with CAR T cell, we do think that maybe a subset of patients will be cured. It's very promising. It can't be done in everybody because it still does have certain types of toxicities with the immune system becoming too active. And it's also, as you can see, very, very expensive. The treatment itself is about $500,000. With everything that goes on in the hospital, it usually ranges between about $1 to $2 million for a single patient for a single treatment. Can I get the next slide? At the UCSF-Washington Cancer Center, we use immunotherapy treatments every single day. You know, that example I gave you of that patient with the Pembrolizumab, the lung cancer, who did well, we use this to treat breast cancer, lung cancer, melanoma, kidney cancers, bladder cancers. It's a very, very frequently used treatment now. And just a few weeks ago, we opened 2 new clinical trials, and we're enrolling patients here at Washington Hospital looking at using immunotherapy drugs in breast cancer. And the first treatment is actually, the first trial that's listed is actually a trial that's trying to improve cure rates. The second treatment is in metastatic breast cancer, so probably won't cure those patients, but hopefully will help prolong their lives. We do refer patients up to San Francisco for additional trials, stem cell transplants, and CAR T cell therapy. Next slide. So in conclusion, immunotherapy is an exciting, rapidly evolving way of treating cancers. There are different forms of immunotherapy. They will not completely replace chemotherapy or other types of treatments for our cancer patients, but it's just an additional way that we can treat patients, and it expands our armamentarium. And there's lots of work being done right now to better define who will respond best to immunotherapy and what combinations of immunotherapies are best. And this goes back to what we call precision medicine, which is the right treatment for the right patient. Are there any questions?
Wow, that was a lot. Well, thank you, David. Any board members have any questions? I mean, it's very encouraging. It's very, some of the things, and frankly, I know some people that are in need of some of these treatments, very expensive, but at least we're making progress, and hopefully the cost will come down over the years, so.
Thankfully, the pharmaceutical companies making the immunotherapy drugs, they have been very generous, though, with drug assistance programs. These are all generally FDA approved, and if insurance will cover it, then that's fine. And if insurance won't cover it, or they just don't have the means, actually many drug assistance drug programs, we just apply for it. It takes a few days, but then they will provide the drug for free. So we've never had a patient who's been unable to get this kind of therapy.
Well, I guess many people might understand this better than me, but I cannot understand how a treatment can cost $500,000. What is it? What is it? And I know there's going to be someone's going to say there's a lot of lead time going into the development of this. I mean, can you explain nobody can afford that really. I mean, why is that?
My cynical perspective, it is they will charge what the market will bear. Unfortunately, it's a market-based system, and they just charge whatever they think that insurers will pay, and whatever insurers don't pay, that difference, they'll just accept that loss.
I'm just astounded. I mean, okay.
Yes, it really is. Unfortunately, even a simple pill where you take one pill a day for cancer therapies, and we have many of these, what we call targeted therapies, that are very effective and very well tolerated, but the price has been creeping up. And let's say there was a drug called imatinib, which was the very first of its kind that was developed in the early 2000s. And back then we were all appalled because it cost about $100,000 to $120,000 per year. And now that pill is upwards to about $220 to $250 per year. And nothing has changed about the medication.
And what's the success rate of these I mean, I think you said that, but I think I probably missed it. I mean,
well, it varies from drug to drug and from cancer to cancer. And so let's say in the case of the CAR T cell therapy, the one that it would cost $500,000, its success rate is actually very good. And let's say in the case of childhood ALL, about 90% of children with ALL are cured with standard therapy. But in the 10% that are not cured with standard therapy, prior to CAR T cell therapy, there really was nothing that worked. I mean, we could possibly keep these children alive for a little while longer, but eventually they succumb to their disease. With CAR T cell therapy, about somewhere around 70 to 80% of those children that didn't respond initially, they are cured. And so they actually will go on and live and potentially can live a full life. So that's an example where while the costs are high, the success rate is very, very good. And certainly we could count on many, many years of meaningful life there.
Do insurance companies actually do this, or are they capped out and require their insureds to pay the difference? Do you know anything about that differential between insurance company payment and insured payment?
Well, with the Affordable Care Act, it did away with lifetime limits. But lifetime limits used to be a major concern in terms of cancer care, because if it were, say, just a $1 million lifetime limit for an individual, we would run up to that very, very fast. In terms of insurance, generally they will cover everything, but there may not cover 100%. It just depends on their policy in terms of what an individual's copay will be, but there's usually an out-of-pocket max for the year.
Yeah. Now, we had mentioned earlier tonight that we lost many years ago one of our really best friends, that was actually the board counsel in his 40s from glioblastoma. And I've seen on TV like 60 Minutes about using a polio virus to attack the glioblastoma in the brain. And I think that's a form of immunotherapy. Is there anything new on that front?
Yeah, so that is a type of immunotherapy. And in terms of glioblastomas, that's been the most effective way of treating that tumor type with immunotherapy. And there's actually other viral vectors that are in trial that they've looked at as well. But that one has been the most successful, which is how it got onto the news.
Okay, so that's still somewhat promising. It hasn't been debunked at all.
No, no, it still is promising, but it's just in trial setting. It's not something that can be done in the kind of in the routine patient care.
Okay, well, thank you, Dr. Lee. Any other board members have any questions? Okay, well, it's a great presentation. I know it's front and center in many of our minds nowadays. So thank you very much. Thank you. Thank you.
Bye.
Okay, Kimberly, we're going to move on then.
All right. Thank you, Dr. Lee, for that and for all that you do for our cancer program and for our patients in our community. Now I want to move on to Dr. Jeffrey Stewart, who's our Chief Medical Officer here at Washington Hospital, and Dr. Ramin Beghi. And they're going to really talk about an exciting program that actually has been part of our strategic plan for a number of years and part of something that we've wanted to implement with an academic medical center for many years that we've been in discussions about this. So I want to just give a little bit of a bio on Dr. Beghi. He came to Washington Hospital in May of 2016. He concurrently joined UCSF School of Medicine faculty in the Division of Adult Cardiothoracic Surgery and assumed the position of Medical Director of the Cardiothoracic Surgery Program at Washington Hospital. Prior to coming to Washington, he has practiced cardiac, thoracic, and vascular surgery at UCLA and Stanford Medical Center. His expertise and experience includes repair of aortic aneurysms and dissections, minimally invasive and cardiac surgery for structural heart disease and coronary disease, and cardiopulmonary transplantation. He has served as the Director of Thoracic Aortic Aneurysm at UCLA, the Surgical Director of Lung and Heart-Lung Transplantation at Stanford University Medical Center and Lucile Packard Children's Hospital, and the Medical Director of Cardiac, Thoracic, and Vascular Surgery at North Bay Medical Center. So they're just going to spend a few minutes and talk to you about the exciting residency and fellowship program that we are going to be implementing.
Okay. All right. Thanks, Kimberly. Can everybody hear me? Can you guys hear me?
Yes, we can hear you.
Great. So yeah, as Kimberly said, this is a very exciting topic and one I've been lucky enough to be involved with pursuing for the last several months. And as Kimberly mentioned, this is something that's been a vision for a lot of folks at the hospital for many years. And really, I agree, it's a great accomplishment for our hospital organization to have this affiliation and build on our partnership with UCSF. And this particular fellowship rotation, we began talks on it this summer, building on some work by several people, but I'd like to mention Tom Pipkin's really been involved with a lot of the work with UCSF and working with the training programs. We hopefully have some other ones in the pipeline we'll be able to talk about in the near future. We had our first meetings over the summer on this in July with myself, Dr. Beghi, who will be our site director for this program, who, as Kimberly gave the background, is the medical director of our cardiothoracic surgery program, and other faculty from UCSF who are responsible for overseeing the residents there on the cardiothoracic surgery program. So we started discussions in July and worked through a lot of the details. It's taken a lot of work from a lot of folks on the UCSF side, Dr. Beghi, of course, support from the medical staff office, the EPIC team with Armando Bravo really helped a lot. I wanted to call him out, and Dr. Hensdorf as well. And it's still really a work in progress because we're shooting for a December start date. So it's a lot still going on in the background. And then the support of obviously the board, Kimberly, and Dr. Killer and the medical staff as well. So it's very exciting. Dr. Beghi is going to briefly, I think, kind of talk about his view of why he sees it as such a positive development for UCSF and our hospital and really the patients of the district. And Kimberly talked about the brass tacks about Dr. Beghi's medical background, but he really has a fascinating background. He was born in Iran, and he went to high school in England and then went to college at Michigan before a lot of what Kimberly talked about, and actually was an engineer working in Silicon Valley before he decided to go back to medical school. So clearly an overachiever, and a great asset to our organization. I've really enjoyed getting to know him. And he's, as Kimberly mentioned, been the medical director of the cardiac surgery program since 2016. And with that, I will turn it over to Dr. Beghi.
Thank you very much, Jeff. And thank you, Kimberly and board members. And thank you so much again for your kind introduction. I would just not take too much of your time. Very briefly, the cardiothoracic surgery residency at UCSF was first approved in 1968, and he has continuously received accreditation by the Council on Graduate Medical Education. Until 2006, it was a 2-year program that people would enter into cardiothoracic surgery residency / fellowship after having completed the entire general surgery residency. And the idea was to train excellent cardiothoracic surgeons who would become leaders in the community or academic or research or combination of. In 2006, the graduate medical education was increased from 2 years to 3 years. That's sort of a reflection of the expansion of the field of cardiothoracic surgery that not only includes cardiothoracic surgery and cardiopulmonary bypass, open chest operation, thoracic surgery, esophageal surgery, cardiac surgery, coronary vascularization, valve surgery, and so on, but also with the extension of a transcatheter technology to have residents be trained in a structural heart program to be able to treat aortic stenosis, mitral valve disease via novel approaches. We thought that it would be very important for our residents and fellows to have exposure to what the cardiothoracic surgery program at Washington Hospital is like. Because we do deliver excellent cardiothoracic surgeries care for our patients in the community. We have a 24/7 ICU staff. We have a cardiac anesthesiologist. So on the UCSF side, they felt it was very important for the cardiothoracic surgery fellows to be exposed with that kind of a practice and understand what it entails to practice cardiothoracic surgery at a very high level at a community hospital, which is away from academic practice. And also, I think importantly is a recognition of the quality and value of cardiothoracic surgery, cardiac surgery, and thoracic surgery at Washington Hospital. I believe this is a feather in our cap that the Residency Review Committee took the application from UCSF and had a favorable approval of the extension of the program. So the idea is that there are residents that would be PGY 6 or higher, postgraduate year 6 or higher, would be able to do rotations at Washington Hospital. They would be still under the supervision of myself and Dr. Teng Li, but they would be able to participate in all aspects of cardiothoracic surgery. I think it is a great distinction for Washington Hospital, and is also mutually beneficial for our residents and fellows to be able to practice and learn more at Washington Hospital. I'll be happy to answer any questions if the board members or the administration or Dr. Stewart have with respect to this program.
I also do want to mention that there will be an action item on the board agenda at the next board meeting to officially approve the program.
Okay, well, any questions, anyone? All right.
I just have can I ask a quick?
Yes, please.
You anticipate having enough for these residents to do here at Washington, that there'll be plenty of opportunity for them to learn a variety of skills and have that experience in the community?
Yes, I think so, Ms. Yi. Primarily, if you're projecting that we'll be doing approximately 125 or so cases, those are major pump cases in 1 year, that would translate to enough number of cases within the course of a week. but also the residency review committee would like the people who are in training to not only learn operative cardiothoracic surgery, but also participate in the preoperative planning and evaluation of the patients, and then perform the operations under the supervision of the cardiothoracic surgeon attendings, and also provide postoperative care and follow-up. We are also hoping to add the transcatheter aortic valve to the armamentarium of the operations that we perform, hopefully within the next couple of months. And I think that would also incrementally increase our volume hopefully by a dozen or so cases, maybe more. We give a realistic expectation of the number of cases and patients that the residents will be involved with, and the residency review committee thought that was a favorable that was important for their training. And then as Kimberly mentioned, Ms. Hart mentioned, that I think if it's approved by the board members, and start having residents, fellows here at Washington Hospital sometime in December, and then we'll reassess what their experience is on an annual basis.
Very good. Thank you. I'm excited.
Thank you, Dr. Beggy. Thank you very much. We're looking forward to all of these advancements. Okay.
I really appreciate your invitation. Thank you.
Oh, yeah, wonderful. Thank you. All right, Kimberly, you're going to move on.
All right, one more presentation. I just want to take a few minutes to really talk about Veterans Day and how Washington Hospital honors and celebrates Veterans Day, and thank those who have served our country. At Washington Hospital, we proudly continue a tradition that we started in 2016. We recognize members of the Washington Hospital Healthcare System family who have served in the armed forces or are currently serving in the reserves by featuring them on a commemorative Veterans Recognition Wall. This wall is located in the Washington West Building. The wall lists the names, military branch, rank, and length of the service of our veterans. I invite each of you to please visit the Veterans Recognition Wall next time that you are in the Washington West Building. The women and men listed on this wall are hospital and healthcare system employees and physicians. They are individuals who work in the hospital or one of our surgery centers. They work in Washington Township Medical Foundation clinics or one of the hospital outpatient centers or other clinics. There are also doctors on our medical staff. Currently, there are 93 names on the wall, including 5 new names that we added this year. The following are the people who have been added to the wall in 2020. The first is Jamie Conley. Jamie is the Director of Nursing at the Washington Outpatient Surgery Center, Napa site. She has been with our healthcare system since 2017. She served in the Army Reserves for 8 years as an E4 specialist from 1996 to 2004. While in the reserves, she worked as a surgical tech. Next is Troy Evans, also works at the Washington Outpatient Surgery Center in Napa, has been on the team since 2018. He is a sterile processing technician. Troy served in the Navy for 3 years and held the rank of E3 hospital man. The next is Javier Flores, is a member of our Food and Nutrition Services team. He is a dietary aide and delivers meals to patients and works in our kitchen. He has been a member of the Washington Hospital family since February 2019. Javier served in the Army for 8 years and held the rank of E5 Sergeant. Michael Mead is the Materials Manager and a scrub tech at the Washington Outpatient Surgery Center, Napa. He has been part of the surgery team since 2017. Michael served in the Navy from 1987 to 1991, where he worked as a scrub tech. He held the rank of E4 Hospital Corpsman, 3rd class. And lastly is Mark Ocampo. He's a certified nurse assistant on our telemetry unit. He joined the hospital this past February. Mark has served in the U.S. Army California National Guard since October 2018 and continues to serve today. Specialist Mark Ocampo is a combat medic in the National Guard and holds the rank of E3 Private 1st class. So as you can see, we have talented veterans on our team. We also support military service and have a policy for employees at the hospital that reflects that. The hospital's leave policy allows members of the Armed Forces or National Guard to be granted military leave from work for the period required when called to active duty for training in active duty training or active duty. Our military leave program allows servicemen and women who choose to continue their military service to be able to do that without fear of not having a job when they return, and without facing financial burdens that are often created when leaving non-military jobs to serve our country. The bravery and selflessness of our veterans is valued and respected. No matter the military branch that these men and women served in, or if they served in peacetime or wartime, we truly appreciate their service. We greatly appreciate the sacrifices they made to serve our country at home and abroad. We thank each of them for their selfless dedication to our country. Thank you.
Okay, well, I just want to say as a veteran, and to those that are listening in and watching, and I've said this before, that my service truly changed my life. And I understand that people thank me for my service, and I just want to say that I want to thank our country for allowing me to have the opportunity to serve. Totally changed my life, changed me from a boy into a man. And so any of you folks that are listening out there about your sons and daughters or grandkids with any kinds of trepidations, I know you should have some, but I know that on balance, it made a difference in my life. And I want to say that I thank every one of you and your families for your service. Okay, Kimberly, now we're going to move on to our medical staff report. Dr. Kilaru is here. Thank you.
Hi, Doug. Thank you. So we have a grand total of 586 members in the medical staff, 348 of which are active. And as Dr. Begi mentioned, hopefully we'll be getting some more cardiac surgery fellows and hopefully down the road some pediatric residents as well that will hopefully increase our numbers.
Okay, well, let's just keep growing. Hopefully we're going to keep growing the facilities for you to practice your trade and care for our residents. And I love it when we keep growing, because the reality is the best facilities and equipment that we have, and we have a tremendous community. I think that attracts the best physicians to our area, and I just love that. So thank you.
And very excited about the hopefully the bond measure going through too, because that will help with the facilities going forward.
Yeah, we're all praying. Yes, we're all praying. All right. So Kimberly, we're going to now move on. Thank you.
All right. This evening we have Mary Baron, our Chief of Quality and Resource Management, and she is going to present the quality dashboard ending quarter ending September 30th, 2020.
Okay, thank you, Kimberly. Yes, starting off with our first slide, going into our infection prevention indicators. Our first one is our MRSA, hospital-associated MRSA bloodstream infection. This is a pathogen that is, of course, very difficult to treat with some of our commonly prescribed antibiotics, and so we monitor this very closely to identify if it's in patients' blood. We have successfully had our 5th quarter in a row without MRSA infections, putting us below the benchmark. Next slide. Vancomycin-resistant enterococci infections, otherwise known as VRE, is another blood-based pathogen that we monitor. This one also is very challenging to treat, even with the strongest antibiotics. And we did have one bloodstream infection this quarter, put us slightly above our internal benchmark. There is not a national benchmark for this, so we have a fairly strict benchmark that even one case will put us over. This patient did not have a central line. which is good, but they had a chronic illness and lots of comorbidities. The next couple slides I'm going to present are our device-associated infection slides, and we have had some real challenges in this area in the past quarter. There's been obviously a increased acuity in this quarter and long length of stay in a lot of our patients, especially as they've been sicker. And we have noticed an uptick in device utilization data that we're monitoring. Starting off with central lines. A central line, of course, is a IV line that goes into a large vessel and is placed close to the center of your body near the heart. And these are high risk for being infected. And in this quarter, we did have 3 central line bloodstream infections. And these cases we're taking very seriously. They all go through a review. We do a root cause analysis. And in doing that, we started looking at some of the best practices that are standards that we should be monitoring and looking at closely. And we have a team who've come up with an action plan associated with trying to improve some of these outcomes. One of them is we are actually doing daily rounds now with nursing and the medical staff to make sure that these lines are only in place when absolutely medically necessary. And we've noticed an improvement the next quarter after this. Well, we're only halfway through this quarter, but from October to November, we do have one, but it looks like it's going down in general. Catheter-associated urinary tract infections is a very similar path because it's a device-associated, and we did notice a significant increase here. This represents actually 7 catheter-associated urinary tract infections. It's the same group of people working on this, and we have actually looked into improving our bundle standards, one of which is having our promotion of our nursing-driven protocol and really re-educating the staff about when this line can come out. It actually is something that nurses have the ability to do on their own, which means that they, when the patient meets certain criteria, we can actually take out this catheter. And so we're looking at making sure we're doing that appropriately. And we have noticed a big decrease here in the last quarter that we're coming up on. We have actually only had 1 infection. So I think we're seeing improvements with that. Moving on to C. diff. This has come down in the last quarter. This represents 10 infections. This puts us at a little less than expected for a hospital of our size and type. And we're really being strict on making sure that patients are tested appropriately and that we are monitoring the antibiotic prescription practices here at the hospital closely, and I think we're starting to see some benefits of that. We had the time prior where we had a low C. diff rate, and then we had that uptick for the last 2 quarters. So again, it's good to see that this is going down again. Moving into surgical site infections. This is something where we continue to see great outcomes. It's a high-risk procedure for surgical site infections because it's associated with the colon, and this is our 5th quarter in a row with 0 infections, keeping us well below the national benchmark. Surgical site infections with abdominal hysterectomies, also again, high-risk procedure for surgical site infections, and this is our 3rd quarter in a row without infections, keeping us well below the benchmark. Hand hygiene is at 86% for this last quarter, 4% below the Joint Commission benchmark of 90%, obviously far above the national rates that you see with hand hygiene that the World Health Organization shares, which is closer to 70%. However, even at 86%, we recognize that this is an area that we want to continue to focus on making improvements. It's the single best way of stopping spread of infection in the hospital. And so we have been actually working with a tool that we've received from Joint Commission, and it's a tool that we use to monitor hand hygiene compliance. It's called the Targeted Solutions Tool. And in this tool, there are multiple areas that we use to measure hand hygiene compliance, what they call observable areas. And each area can If any area is missed or any opportunity to perform hand hygiene is missed, it's regarded as non-compliant. So what we're learning with this tool and reading in what Joint Commission is recommending is that once we have completed these hand hygiene observations, we share them with the staff, which we've started to do, and that means all healthcare workers across all disciplines. And it's important to share with them sort of how we monitor their hand hygiene, all the opportunities they have to perform hand hygiene. And at the same time, it's a good opportunity to get feedback from the healthcare workers about sort of what are their barriers that they're experiencing when doing hand hygiene. It's typical that when you have that conversation, you'll hear things about, were they interrupted? Did they understand that you have to do things like even wash your hands prior to glove placement? That's a really common one that is misunderstood. And having the availability of hand hygiene that's in a convenient location. So we'll continue to work with that tool and the staff through the Patient Safety Committee and hope to see that improve. Moving into our nursing sensitive indicators. Our first one is our inpatient falls with injury. Obviously, we've seen a significant increase here. This represents 3 falls. And of the 3 falls, I want to first say that the injuries that the patients had did not result in any a severe or a life-threatening injury. Nevertheless, even if it's an abrasion from a fall, it's something that we take very seriously. And 3 falls is 3 falls too many. And so we have all of these falls are reviewed through our dedicated falls committee. And again, we do a root cause analysis and kind of look back to see what could we have done to prevent this fall. And in these 3 cases, one of the things that came up is that obviously we're managing a lot more square footage now, and patients are all in private rooms, which is great for many reasons related to quality and patient experience. But it's a space we're still sort of navigating through. And we have to make sure that these patients are as visible as possible to the nursing station. They have nurses close by charting, even if they're at a different area. And so the committee has really looked at this and is looking at ways to improve visibility. We're also putting baby monitors in the patient rooms so we can watch closely from the central nursing station. And we have seen an improvement in this. We actually have had 0 falls in October and so far in November. Hospital-acquired pressure ulcers is an area that we have had 0 on for the last 2 quarters. This is good considering, as I mentioned prior, that typically when you see a higher acuity, this will be one outcome that increases. This was out of 70 observations, and we were well below the national nursing benchmark for this. Moving into our readmission rates, we've obviously spent the majority of this year focusing on steering and COVID prevention, and over this last quarter, it was really a time to get in and refocus on hospital initiatives. And one, of course, being reducing readmissions and unnecessary visits back to the hospital for patients that Medicare is focusing on, which are of patients typically over the age of 65. And with pneumonia being one of the conditions that they look closely at, we were over the benchmark, having 24 readmissions, which is actually 20 patients. A couple of them came back on multiple occasions, puts us at 28.6%. And there are a bundle of interventions that we have to do for all of the conditions. Many of them overlap and are similar. There are certain interventions, though, that do tend to help conditions more. In the case of pneumonia, it's really important that these patients have home health visits when they go home, and that we keep a close monitor on them to make sure that they don't further develop and have issues around sepsis. And with these patients, that's what our focus on is in the area, is the transitional care afterwards. AMI, otherwise known as a heart attack, is another area where we did see an increase. This is actually 5 patients, but total of 6 encounters, putting us above the benchmark. And we've been below or at the benchmark for the last 3 quarters. So we looked at these cases, and there are multiple issues going on with these 6 patients. In fact, we're on quite a bit of medications and had some chronic underlying illness. But one of the interventions that we've really focused on in this group is making sure that a pharmacist does a face-to-face visit with these patients prior to discharge, going over all their medications. The medications change frequently. It's very confusing understanding the indications, and we have to make sure that they're getting the right medication at the right time, even as they transition back home. So that has been our focus area for AMI. For heart failure readmissions, this is seen a slight increase. We had 18 readmissions here, over 15 patients. So of course, putting us over the benchmark. Heart failure, the main focus here has been a lot of chronic illness management for a lot of these patients are dealing with multiple chronic illness issues. And one of the interventions that has been shown to reduce readmissions is making sure that these patients have a follow-up phone call and that there's a lot of contact with them afterwards to make sure that they're doing their daily weights, taking their Lasix medication, and making it to their follow-up appointments. And again, these are things that we do for all of the high-risk readmission groups, but in particular with heart failure, this has been our focus area that as we refocus on this initiative, we were hoping will help decrease the number of patients who have to come back to the hospital. Coronary artery bypass graft, otherwise known as a cabbage procedure. We did not have any readmissions for this last quarter. We obviously do multiple types of cardiac surgery, but in this particular, it's just focused on the cabbage, so that's why it was only out of 2. As you know, we have a large volume of patients who receive their total hips or knee replacements here at our hospital, and we have in spite of having this large volume, majority of our patients for the last 2 quarters have actually been moving towards an outpatient classification because Medicare has allowed for this procedure to be classified as outpatient. And we just have in the last 2 quarters noticed that because of this shift, our denominator is much lower than we would typically see. In the quarter of 9/20, this is out of 47 procedures because, of course, those were the only ones that were classified as inpatient. Still far below the benchmark, but we did have 1 patient who came back and was readmitted. COPD also is a risk that CMS and looks at very closely for readmissions. We did have 2 patients come back out of the 16, another group of patients that you have to really manage from a chronic illness standpoint. And so we're looking closely at making sure that these patients all have a follow-up phone call, that they make it to their physician follow-up appointment, and also really focusing on performing home health for these patients.
Wow, okay. That's very well. Thank you. Thank you, Mary. Thank you very much. Any questions from any of the board members? That's a very thorough report. Thank you. Thank you very much.
Thank you. And I recognize it's been a very challenging quarter for us, and but we will continue to focus on the actions and hoping to return with better outcomes in the future.
Yeah, to say the very least, it has been actually more than just 1 quarter. I mean, it's just like, wow. This all began in March, and I think, and it's been tough, and you and the hospital staff has been exemplary in taking care of our residents, and thank you so much. Thank you.
Thank you.
Kimberly, do you have anything else before we adjourn to the?
So we do have the next is Chris Henry is going to do the financial report. So
well,
we do have that.
Well, no, I wanted to forget that because I mean, I know that, you know what, that is misery. There's nothing worse misery than the financial report at every hospital in the United States. So our numbers are not great, and neither is any hospital in the United States, because the elective surgeries and many of the procedures that people should be taken care of that are not really elective, they're afraid to come to the hospital. And I know that our hospital is totally safe, and but you can't deal with the fact that folks are worried about their health and their loved ones from COVID. And so I know that our numbers are down, but the good thing is that we are financially strong and that we can weather this storm, whereas many of the many hospitals throughout California and this country cannot. And I don't know how it's going to end up. Hopefully this vaccine will work, and folks will get more confident in coming to the hospital. But it's not surprising our numbers are horrible, and that's just the way. That's just our life right now. So go ahead with your finance report, and hopefully none of the board members will jump in and beat you up, Chris. But you don't deserve it.
That'd be a bonus. Thanks, Mike.
Yeah.
Okay, so tonight we're gonna look at the results of operations and the resulting financials for September 2020. And as always, we'll start with our acute inpatient statistics. Average daily census and patient days for September were both up by about 2.8%, yet our admissions were off by about 5.7%. And that's an indication that we had a longer length of stay. You see down at the bottom of the page, our average length of stay for September, and this one's based on discharges, was 0.97, almost a full day longer than what we had expected in the budget. And this is an indication, we'll see the case mix index in just a second, of really a higher acuity of the patients that are coming to the hospital, as Director Wallace just explained. Outpatient observation equivalent days for September were 55, above budget, almost a third, at 214. Moving into utilization again, our case mix index, as I just mentioned, remained high, even higher than last month at 1.679. Normally, we would expect a case mix index at about 1.443. Deliveries for the month were 19 below budget at 113. Our surgical cases, not too bad, 11 below budget at 367. That includes our joint replacement cases that were just one below budget at 158. Good news is our neurosurgical cases and cardiac surgical cases were both above budget by 5. So really that variance being driven in general surgery area. Cath lab procedures for the month were 28 above budget at 380. We had 7,092 outpatient visits for the month, 15 above the budget of 7,077. It's good to see those numbers starting to hit budget, but we're still well below where we were last year. Emergency visits for the month, this excludes, we broke out the RSTU visits for you this month. So regular emergency room visits for the month, 442 below budget at 3,482. And again, that may be an indication of the fear that Director Wallace was just talking about. Our RSTU visits for the month, then these are really our COVID tests. Thankfully, 794 below budget at 1,260. A quick look at the cath lab distribution of activity, both peripheral and vascular and cardiac activity, very close as a percentage of the total activity, 37% for cardiac, 38% for peripheral vascular. Non-vascular interventional radiology procedures for the month made up 24% of the volume, and neurointerventional radiology, 1%. Moving into FTEs. Productive FTEs for the month were 141, higher than budget at 1,366.5. We had non-productive FTEs for the month coming in at 181.1, giving us total FTEs about 137 above the budget at 1,547.6. Our FTEs per AOB, which is our productivity indicator and an indicator of how well staffed we were for the volume we had, above budget by 0.48 at 6.94. This is an area that we've really been struggling with COVID. And you know, it's a kind of a rock and a hard place scenario where one factor that's impacting this is that the daily census has been very volatile, you know, bouncing around from between 110 and 115 to as high as 160 today, and just really bouncing up in between that range from day to day. The other issue we have is trying to balance staffing for the activity versus being prepared for what everybody is warning could be a really horrendous winter insofar as flu and COVID activity. And the issue is that if we shed our FTEs, there really aren't any agency nurses or clinical staff available out there. They're all being pretty much utilized in other areas, and if we let them go, we may not get them back. So it's trying to balance being ready for what we're being told is the coming storm, and yet trying to flex down in this time of lower activity. And Kimberly, do you have anything to say on there?
Well, I think you'll see some of the same challenges in October when I do the operations report. I think we realize we do need to, and we put in place some initiatives to continue to look at flexing and being able to respond better to the changes in the volume. So we recognize we do need to improve in this area, because you will see the same struggle in October too.
So moving into the financials, total patient revenue for the month came in $5.9 million higher than budget at $171,974,000. Payer mix for the month continued to be higher than we had hoped in the budget at 77.94%. Really, the payer mix has been rough. Our government-sponsored patients made up 72% of our gross revenue versus a budget of 71%. PPO came in at 23.2%. We had expected 24.2%. And our HMO cases actually came in higher than budget at 3.1% versus 2.46%. So we end up with our contractual allowances for government-sponsored patients and third-party insurance-sponsored patients coming in at 75.81%, higher than the 75.58 we expected. And our provision for bad debt and charity came in a little bit higher than we had hoped as a percentage of gross revenue at 2.13% versus 2.05. Moving into expenses, well, first of all, so after contractuals and provision for bad debt and charity, we ended up with net operating revenue for the month $756,000 higher than budget at $38,244,000. Operating expenses for the month came in just under $3 million higher than budget at $40,854,000. And of course, the salaries resulting from those higher FTEs driving the majority of that variance Also had higher than expected expenses in the area of supplies. That was above budget by about $253,000, and down a little bit lower in the area that's called taxes, insurances, and other. We had an other classified, an other expense related to the Medicare Shared Savings Program. We did receive a bonus from the Medicare Shared Savings Program, but we paid out an amount to our partners in that program, and so that drove that category above budget by about $379,000. So we ended up with an operating loss for the month, about $2.2 million greater than we expected in the budget at $2.6 million. Non-operating income for the month came in with actually a loss of $216,000 versus a $70,000 expected income. That driven largely by an unrealized loss on our investment of $239,000. So we ended the month with, of course, this is our Governmental Accounting Standards Board format, with a net loss about $2.5 million higher than we expected at $2.8 million. So moving into the Financial Accounting Standards Board format, this is the way the financial markets would really adjust those financials we just looked at when they evaluate us. First thing we do is we reclassify the interest expense related to our revenue bonds, about $700,000, out of non-operating back up into operating expenses. So we end up with operating expenses from a FASB perspective of $41,573,000, and an operating bottom line, again from FASB perspective, almost $2.2 million greater, actually a loss, almost $2.2 million greater than expected at $3.3 million. Non-operating income, then we remove the interest expense related to the debt service on our general obligation bonds, and we remove our unrealized loss on investments, as well as our tax revenue. And we end up with non-operating income from a FASB perspective about $112,000 lower than we expected at $440,000, and a total bottom line actually showing a loss of just under $2.9 million. Quickly looking at earnings before interest, taxes, depreciation, and amortization. This gives us an idea of how much cash the operation generated for the debt service and for future capital expenditures and such. We remove the depreciation expense from our operating bottom line, which is really a non-cash item, to come up with EBITDA of almost $1.4 million in September. We also go down below into non-operating, and we parse out the interest expense. So we come up with earnings from non-operating activities of $1,648,000. So in total, the operating and non-operating activities of the hospital generated about $3 million for debt service and other capital spending and such. So are there any questions on the September results? Okay.
All right, why don't we move on to,
why
sorry,
don't you?
go ahead.
Is there a question? Anybody have a question? Okay, why don't you continue then?
Okay. All right, I'm going to present.
Wait, I guess I do have a question. So the EBITDA that we have generated, is it before the debt service that we have or after the debt?
Yeah, it's before the debt service. Yes.
Okay, and how much is the debt service?
The debt service is about $1.7 million a month, $1.7 million, $1.8 million.
Oh, okay. All right.
Yeah.
Well, thank you.
Yeah.
All right, I will present the operating report for October 2020. It is very similar, as you will see, to what we saw in September. So the gross revenue of $173.7 million for October was above budget by $7.6 million or 4.6%, but just below the October of 2019 by $0.5 million or 0.3%. Our inpatient gross revenue of $108.4 million was above budget by $5.5 million, but $7.7 million below the October of 2019. And outpatient gross revenue of $65.2 million was above budget by $2.1 million and $7.2 million above October of 2019. And again, it's a lot of the shift of the joints to outpatients. All right, in terms of the key census statistics, average length of stay of 5.16 was above the budget of 4.89 or 0.27 or 5.5%, resulting from the higher acuity of admitted patients. The average length of stay was also longer than the October 2019 average length of stay of 4.82 by 0.34 or 7.1%. Again, this is due in part to the shift of the joint surgeries from inpatient to outpatient and also the higher acuity. Outpatient observation days were 20 or 11.6% above budget at 193, and outpatient observation days were 10.3% above October of 2019. Our daily average census was 133.4, which was above the budget of 131.9 by 1 or 1.1%. And the average daily census was 12 or 8.1% below October of 2019. The admissions trend you see continued to be lower than budget, and it was below budget by 104 or 12.4%. Admissions for the month were 218, 22.9% below October of 2019, due in part again to the joint surgeries from inpatient to outpatient and a lower volume in general, due to people, we believe, delaying their care. Patient days of 4,135 were above budget by 46 or 1.1%. Patient days for the month were 8% below October of 2019. Looking at our total surgical trend, total surgical cases in October of 381 were above budget by 7 or 1.9%, and surgical cases were 10 or 2.7% above October of 2019. Our inpatient surgeries were 9 or 4.9% below budget at 175 and 56 or 24.2% below October of 2019. Our outpatient surgeries were 8.4% above budget at 206 and 47% above October of 2019. Breaking down our surgical activity, general surgical procedures were below budget by 1. Joint replacement surgeries were below budget by 1 or 0.6, but they were 13 or 9% above October of 2019. Our cardiac surgery procedures were above budget by 3, and they were 3 or 30% above, again, October of 2019. And neurosurgical procedures were above budget by 6. They were 2 below budget compared to October of 2019. So overall, there was some strength in our surgical activity. Moving on, I did want to just show this slide one more time to the board, and this really shows in terms of our joint replacement surgery trend. So if you remember, prior to fiscal year 2019, the vast majority of our joint replacement cases were done as inpatient cases. When CMS removed the total knee replacement from the inpatient-only list in 2018, you can see that relationship changed to roughly 50% inpatient and 50% outpatient. Now that CMS has removed total hip replacements from the inpatient-only list, the majority of total joint replacements are being performed as outpatient cases. And you can see in October, approximately 77% of all our joint replacements were performed as outpatient cases. Moving on to our cath lab activity, our cath lab procedures for October of 330 were 30 or 8.3% below budget, and 159 or 32.5% below October of 2019. Our inpatient cath lab procedures were below budget by 42 or 20.4%, and 47.9% below the October 2019. Our outpatient cath lab procedures were above budget by 12 or 7.8% and 166, but below the prior year by 8 or 4.6%. So breaking down the cath lab activity, you can see in terms of some of the areas that we were not meeting budget. Peripheral vascular procedures were below budget by 45 or 28%, and 132 below the same period last year. Our neurointerventional radiology procedures were below budget by 9, and 10 were below October of 2019. Our cardiac procedures were above budget by 11, but 11 below October of 2019. Our non-vascular interventional radiology procedures were above budget by 13, but 6 below October of 2019. If you remember, we did have Dr. G, who was with Dr. Bruce Lin. He left. We have recruited a new physician, Dr. Hansra, into the practice, and he is starting to improve and, or I should say, build his caseload. And so we should hopefully be seeing additional procedures from him. Moving on to deliveries, our deliveries for October of 115 were below budget by 18 or 13.5%. We've continued to see deliveries below budget. I know some of the other hospitals are experiencing the same sort of lower delivery numbers than in the past, so we'll have to continue to look at these numbers going forward. Let's see, our non-emergency outpatient visits were 7,912, which were above budget by 332 or 4.4%, but they were below budget, below October 2019 by 836 or 9.6%. In terms of those numbers, EKG visits were above budget by 103. Our lab visits were above budget by 325, and our cardiac rehab visits were below budget by 210. Our emergency room visits, they were 3,530, which were below budget by 373 or 9.6%, and were below the same period last year by 754 or 17.6% visits. So our emergency room continues to see lower numbers than we have seen in the past. And I think this, again, is a trend I know that many other hospitals are experiencing too. Moving on to our rapid screening and treatment unit, RSTU. You can see there were 1,894 visits. That was below budget by 228 or 10.7%. We have been seeing a decline in the number of visits to the RSTU, but saw a slight increase this month in terms of just seeing additional potential exposures in the community. Moving on to our gross revenue recap, emergency room visits were below budget by 373, driving emergency room revenue down by $1.2 million or 11.2%. Inpatient days were above budget by 46 or 1.1%, and patient acuity was high, driving room and board revenue up by $1.2 million or 3.7%. Our surgical cases were above budget by 7 or 1.9%, and the procedure mix was favorable, driving the surgical services revenue up by $3.8 million or 11.3%. A higher level of inpatient activity and acuity drove the ancillary services revenue above budget by $4.6 million or 6.2%. Looking at our preliminary payer mix, we still have some challenges with this. Government-sponsored patient revenue made up 73.1% of total gross revenue. This is higher than the budget, but lower than the prior year. HMO was 2% of gross revenue, which is below the budget of 2.6% and lower than prior year 2.3%. Our PPO revenue was 23.3% of gross revenue, which is below the budget of 24.3%, but it is higher than the prior year of 22.2%. And then lastly, our private pay was 1.6% of gross revenue, which is below the budget of 2% and lower than the prior year of 2.1%. Moving on to our productivity indicators, our productive FTEs were above budget by 99 or 8.2% at 1,310.8. Our non-productive FTEs were below budget by 9.8 or 6.3% at 147. So our total FTEs of 1,457.8 were above budget by 89.2 or 6.5%. Looking at our productive FTEs per adjusted occupied bed, they were at 6.14, which is higher than the budget of 5.70 by 7.7%. And our total FTEs per adjusted occupied bed of 6.82 were higher than the budget of 6.43 or 6.1%. And as I think, Chris reflected on this, and also, as I said, we are putting in place initiatives in terms of working on flexing to the budget numbers. So that is something that over the next few months we are focusing on. All right, other operational statistics. Washington outpatient surgery center cases were below budget in October by 26 or 5.1% at 482. Our clinic visits of 3,173 were below budget by 233 or 6.8% for the month of October. Our Washington urgent care visits were down by 288. This is an area we still have seen a lower volume, similar to what we're seeing in the emergency room. They've been down. Our Danielson Clinic and Nakamura Clinic have been up, and our Warm Springs Clinic was down, but we do have a new physician that will be joining there, or that has joined the Warm Springs location. Moving on to key financial statistics. Our days cash on hand for October ended at 172 days, a decrease of 4 days from last month. The 2 days was due to increases in operating expenses, particularly the salaries and health benefits. And the other 2 days increase in funding for surgery center until financing is secured. So as you know, we're in the process of getting a loan for the Peninsula Surgery Center, and so then once that is secured, then that money, that you should see these days go back up. In terms of days of gross revenue and accounts receivable, we're 60. Higher volume of high dollar, high acuity patients compared to last year is really driving that. And then for charity care, there were $367,688 in charity care applications pending or approved in October. Then lastly, looking at our summary of homeless patient activities, there were 179 homeless patient encounters in October 2020. Homeless patients were with more than one encounter accounted for 26 of the 179. The estimated incremental cost for the month of October is approximately $59,000, and the total unreimbursed cost of homeless care for the month of October was $580,000. And looking at the total estimated unreimbursed cost of homeless care for fiscal year is approximately $1.7 million. And then lastly, just breaking it down in terms of, you can see in the bar graph, the red portion of the bar graph represents the monthly estimated incremental cost, and the yellow portion of the bar graph represents the monthly total estimated unreimbursed cost. Are there any questions on the operations report for October?
Well, it's totally 100% misery. but I mean, we just have to wait and hope that things are going to improve, and that, like every other hospital in the country, probably in the whole world, we're going to need government assistance at some point. Quite likely, we're going to be like the last that's going to need it because our financials are so strong. But at some point, this is really trying. It's really trying. I know you're doing all you can do. and I know you've done great so far in getting government assistance and grants, and we just have to be prepared to do more. I think it's probably going to get worse with the COVID and the flu coming upon us, and we just got to keep the faith. That's all. And just think pleasant thoughts, and keep doing our job, and don't let our dopper get down. So let's just.
Yeah, we continue to look at initiatives that we're looking at implementing in terms of in different areas. So there are areas that we feel that we can look at improving upon.
Yeah, I know. I noticed that the correlation between our, when you were talking about the flex scheduling, I mean, I at one level, I think, okay, well, we had in our budget a belief that we would have X patients and Y staff to care for them. And I don't know that all that is coming together, as it should be. And I know you're focused on that, so I don't want to dwell on that. But and it's kind of like in my own life with the bank, you just never know. As soon as you cut staff, then you have a flood of customers or patients that you have to deal with, and then you're just totally a mess. So it's hard to predict these things, and so just do your best, and and we're all there for you. So I know you're trying your best.
Thank you.
Okay. Okay, we're going to move on to our action item that we have.
Yes, we have one action item this evening.
Mr. President, I move for the adoption of resolution number 1218, which is a resolution of the Board of Directors of Washington Township Healthcare District approving the issuance and sale of and determining the proceeds with the negotiated sale of certain refunding bonds of the district in an aggregate principal amount not to exceed $51 million, approving the execution and delivery of a supplemental indenture, a bond purchase contract, an escrow agreement, a continuing disclosure agreement, a preliminary official statement, and certain other actions related thereto.
Thank you, Dr. Epen. Do I have a second?
A second.
Okay, I would just like to say this is one thing that is a positive. We are refinancing higher rate bonds to a lower rate in order to save money. And I think that's a great thing, like many homeowners are doing now. And well, everyone's taking advantage of the low interest rates. And so I think it's a wonderful thing. So thank you, Kimberly and Chris, for bringing us forward. And so, Dee, would you please take the vote, please?
Yeah, I mean, I will just say that as Director Wallace stated, I do want to say the estimated cash flow savings is approximately $1 million per year on average. And just so that everybody aware, it is the district's 2010 Series A revenue bonds totaling around $48.6 million. And so the current average coupon rate of these bonds is 5.43%. And based on current conditions, we estimate a new average interest rate of approximately 2.8%. But as you know, as we all know, that it will be determined on the date of the sale. So I just wanted to make sure everybody was aware of that.
Oh, okay. Well, thank you for that color. Thank you, Kimberly. Okay, so Dee, will you take the vote, please?
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Epen,
Right?
Director Stewart.
Aye.
Okay, well, that motion passes. Okay, Kimberly, are there any other items that you or any of the board members would like to talk about in the open session tonight?
I do just have a couple of announcements. I do want to tell about the November Employee of the Month, and that's Joyce Calixto, and she's an RN, MSN, and she's a staff nurse too on 4 West. So after several years working in pharmaceutical research, Joyce decided to get out of the lab and into direct patient care. Joyce went back to school and earned a nursing degree. In 2011, Joyce joined the nursing staff of Washington Hospital, and she couldn't be happier. She says it was invigorating to return to school and develop a new career, one that contributes to patient health care every day. Since joining the Washington family, Joyce has earned her master's degree in nursing and certification as a medical surgical nurse. Joyce sits on the Hospital-Wide Educational Council, where she represents 4 West, sharing essential information with the unit. When she describes the best part of her job, Joyce focuses on 2 areas: her coworkers and the patients on 4 West. Joyce describes the staff of 4 West as a team that on a daily basis works together to help the patients and each other. Her coworkers are quick to comment that Joyce is always willing to do what is needed to help the team. She is an excellent leader who helps as both the charge nurse and the break nurse. Joyce encourages her coworkers through example. She always puts the needs of the patient first. So congratulations, Joyce Calixto. She's the staff nurse on 4 West. And then just quickly, a couple of other things. I just want to say that we had a very successful think tank on October 15. It was by Zoom, of course, and we had 160 community members that participated in the event. And then since that time, 86 people accessed the presentation. Then on October 24th, the Washington Township Medical Foundation hosted a flu vaccination drive through the Nakamura Clinic. And we had 171 community members receive their flu vaccination. So we've done a number of flu vaccine clinics, and it's really important, as we all know, to ensure that everybody gets their flu shot. And then lastly, on Wednesday, November 4th, Dr. Catalina Villa, she's a psychiatrist, presented emotional wellness during the holidays, and 68 people participated in the live event, and 23 people accessed it. And lastly, I just do want to do a plug that the Masquerade jewelry sale will be online this year. And so it can be found on www.masqueradefundraising.com. And if you use the code 5238 at checkout, then our service, part of the money is donated to our service league. So I just wanted to do that one plug. So
Thank you.
That's all that I have.
Well, thank you. I mean, yeah, that's a very important program. I just want to say that the psychology program that you had was really well attended. And I think that we need to continue to focus on this. I know that the stress levels in our community are rising, and I think they're probably going to get worse. And so the more that we can do to facilitate dealing with the pressures that are on everybody, I think it's going to be it would be really needed. And I know that you're thinking about that because you have a great program already. Just I want to encourage you to continue it and do more.
Yeah, I agree. I think it is a need. I know that is one of the areas that we continue, community organizations and others continue to outreach to us in terms of needing help in that area, both in adult and adolescent. So it is an area that we're continuing to look at ways that we can offer information and assistance to the community.
Yeah, I mean, I know normally at this time of the year, things get kind of really stressful without the COVID. So I know it's going to be accelerated with the COVID. So, okay, well, all right. Well then, enough said. So, are there any other issues any board members want to discuss, bring up? All right, then we're gonna now go into a closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you, and the board will now adjourn to a closed session.